So we're going to talk a little bit about what the literature has to say in the Emergency Medical Abstracts database with regards to nasal emergencies. And nasal emergencies, it's interesting when you talk to people about nosebleeds and things like that. They either love them or they hate them. I kind of like them. I think it's a nice sort of procedure-oriented thing. You can usually manage them. They're pretty straightforward most of the time. When they're bad, they are bad though. And if you see a posterior nosebleed and you're having trouble controlling it, you know, we'll talk about that a little bit, but things have gotten even worse with regards to that, because it used to be that you just called an ENT and said, I need surgical control of this bleeding, and now ENT tries to duck out of the way and say it's interventional radiology that needs to be called. And so, you know, finding an interventional radiologist, I don't know what your system is like, but even in big systems where they so supposedly exist and are available, they're hard to come by. First thing we're going to just touch on is someone comes in with a nosebleed. Do they need to have coag testing? Do you need to know what their platelet count is, their hemoglobin, their pro-time, and God forbid their PTT, like they got new onset hemophilia? And the answer, I think, from a common sense standpoint is no, that generally speaking, coagulopathies are not the basis of most nosebleeds. When we talk about nosebleeds, and particularly if you want to take kids, and in the pediatric population there are some undiagnosed coagulopathies. In kids, you would say that the cause of nosebleeds are the 3 Ds. The first D is dry nose and mucous membranes. So dryness and trauma and Kesselbach's plexus erodes and bleeds anteriorly. The second D is digital trauma. People pick their noses when they're awake, when they're asleep, when they're conscious, when they're unconscious. All you got to do is look at people next to you in their car. It's clear they believe they're invisible. And you'll see some major mining corporations at work going on. And so that's number 2. And the third D is DNA, but the third D is the weakest. Number 1 is a paper from Scotland. As we've already kind of alluded to, the UK, anything you see from the UK and most of the stuff from the Europe, they're pretty much nihilists. If they ask any question about what needs to be done, and it's a UK sort of paper, Europe paper, the answer generally is nothing. Like the Swedes published the paper that everyone loves to talk about with regards to back pain. Untampered back pain has the best outcome. You know, talk to them, make sure there are no red flags, and tell them that back pain is a consequence of walking on your hind legs. You really don't have much choice about it unless you plan to go back to all fours. You know, that's what it is, and you'll do better. Get on with your life. And this paper is a typical Scottish paper that says that, yes, there might be a role for coags, but you need to have something in the history or physical that would lead you to believe that they're there. They're certainly not routinely necessary. There, you could start thinking about getting coags if this is like the 5th or 6th episode, particularly in short succession, recurrent episodes. You could think about it if the person's obviously on anticoagulation meds. By all means, have at it. Get your pro-time. They're on Coumadin. Find out what their INR is. Find out if you need to hold off on the Coumadin or maybe even entertain vitamin K. And we can get into the controversy about how to give that vitamin K, but I believe most of the time just holding the Coumadin will work. And secondarily, if you were going to go to vitamin K, most of the time orally is the route to give it. And if there's a family history that suggests there might be other bleeding disorders, then you might add some other things. You might even consider a PTT if there's some history of hemophilia or some history of von Willebrand's disease. You might add a ristocetin test. But outside of those obvious history and physical indicators for testing, testing is not routinely indicated. It's a very common sense paper. The data contained within it is not particularly compelling, but if you're looking for a resource that says these aren't routinely, you know, if someone says you got to get these all the time, they're not routinely indicated. Abstract 2 is a paper that takes the opposite side, but it really highlights how papers can reach the wrong conclusion more than a good defense of the opposite side. This is a paper where they had 34 patients. They say that this paper, the authors would say, it justified screening. These 34 patients that they had, of that 34, 8 were on warfarin, one had von Willebrand's disease, and there were 3 surprises in there, and so they said that there were actually 12 out of 34 patients with some coagulation problem that justified screening. That just can't be right, and you know that because 8 out of every 34 patients you see aren't on Coumadin, so the population is some sort of selected population. The incidence of von Willebrand's disease is not 1 in 34. It's 1 in 3,400, something like that. I don't know what it is actually, but it certainly is not. I know it's not 1 in 34. And so this is a paper that shows if you have a small population, if you're going to justify common tests, you need to have a large enough sample size to be reflective of the conclusion you're trying to reach. This sample size is too small. It's got a weird sort of complement to it, and so they come up with a wrong conclusion. I think that this paper actually supports the conclusions of number one. On the 8 people who are on Coumadin, get a test. On the 1 person with a family history of bleeding disorders, von Willebrand's, get a test. And the 3 surprises, now we're down to 3 out of 34, and I don't think those would hold up really well. PEDS nosebleeds, abstract 3 is another one that shows how you can get the wrong conclusion. So abstracts 2 reaches the wrong conclusion because they just had too small a sample size, and that sample size had weird components to it. It wasn't reflective of the average population. Number 2 is another kind of paper that you'll see in emergency medicine. I don't know if Di talked about the incidence of nerve injuries in shoulders, but if you ask the orthopedists and look in orthopedic papers, they'll tell you that the incidence of axillary nerve injuries and shoulder dislocations is 10%. Ask any emergency physician, they'll say it's not 10%. I see these all the time. It's not 10%. It's like, well, it's 1 or 2%. I don't know where they get this. It's rare. Well, that's because we send the orthopods, all the ones where the nerve is out, and the people who have a nerve out actually go to the orthopod. Most people who've dislocated their shoulder for the second time, who you refer to an orthopod who got nothing wrong with them, are like, why am I going to go and spend $450 over there when he's going to leave me in the sling and do nothing? That's what he did last time. That's what he's going to do this time. I'm not going there. And so there's a referral bias where the people with more severe entities select themselves, appropriately most of the time, to be seen by the specialist. And that's exactly what happened in Abstract 3. It's a referral population. It's a heme-onc clinic. Now, most of your nosebleeds, of course, you send them to hematology oncologists, I'm sure. No, you don't. Most of them, you stop the nosebleed and say, there, don't pick your nose and keep it moist. Because it's the first 2 Ds that seem to be the operative feature. And they never get seen by a hemonc. In this population of kids, mostly recurrent nosebleeds, so they were appropriately selected. These were kids who had kept having nosebleeds and episodes of this, and so the doctor, either a primary care person or an ER doctor, flared their nostrils, sniffed the bouquet of the child, and said, there's something wrong here. And most of us would say, if we really think there's something wrong with the blood, fine, they could see a specialist for this. I mean, these are, even ristocetin testing, for example, is a kind of complicated affair. If you look up von Willebrand's disease and testing for it, it's a little bit of a complicated affair. I mean, I don't want to oversimplify it. So the docs did the right thing. They flared their nostrils, sniffed the bouquet, said something's wrong, see a specialist. And when they did that, 1/3 of the kids in this referral population had a coagulopathy, 1/3 of them, half of which was von Willebrand's. And so this serves as a reminder that in the pediatric population, von Willebrand's disease is out there. It's smoldering around, and you'll see it in young women when they start menstruating, who, they're having their first kind of anovulatory cycles and are having menometrorrhagia already, like, welcome to the world of being a woman, disaster. They're thinking, what do you mean, I bleed to death for 10 days every time this happens? And among that group, you'll find some von Willebrand's disease. And likewise among the nosebleeds, and likewise if you were to look along the dental bleeds, you'll find von Willebrand's disease smoldering around. You'll even find it occasionally in some adults. But there you go. So that was in there. And so this is a test this is a paper that reminds you, among a population that's having recurrent problems selected to go, indeed, you might consider coagulation testing and even things like ristocetin tests to start looking for von Willebrand's disease. Abstract 4 is a paper that tells you that to remember that keeping the nose moist, and if you put a big of something up someone's nose, polysporin, even Silvanine would work, but anything like that when they've had a nosebleed, it serves 2 functions. 1, it keeps the nose moist, and 2, every time they go to stick their finger up their nose unconsciously, they go, yeah, what was that? Oh, yeah, I got that stuff up there. So putting Vaseline even is fine, or PBN, polysporin, any of those things up the nose when someone's had an anterior nosebleed that you've controlled, works by 2 mechanisms. 1, keeps it from drying out, and 2, keeps it from being re-injured with digital trauma. And so those are things. Now, in terms of controlling nosebleeds anteriorly, we could talk about some of these things, but one of the things I would say is that if it's a very simple Kesselbach's plexus thing, you could try cautery sticks, but my impression of cautery sticks is not very good, and I don't know how you in the audience feel about them. They will work. The problem is you put a cautery stick up there, a silver nitrate stick, and it kind of and the little smoke things, they invariably sneeze shortly thereafter, which of course restarts the nosebleed because of the surge of pressure associated with the sneeze. So I'm more in favor of actually packing the anterior nose as a way of control, and there's now such great packing devices. We'll talk about some of them in a moment. Now, in terms of stopping nosebleeds, you can put vasoconstrictors up there and they work. What's the best vasoconstrictor to put up the nose? Cocaine. It's absolutely the best. Cocaine gives you the triple whammy. Cocaine is beautiful. It's a vasoconstrictor, like that. It's an anesthetic, like that. It's a decongestant, like that. It makes for happy patients, like that. But it's got a downside. There's an abuse potential, obviously, both of the patients and staff. And there's a coronary artery vasoconstriction problem. How much cocaine are you given? How many of you have used cocaine in the past? And I remember in an ER when I was a medical student, they used to have these big ampules of 10% cocaine was what was pharmacologically available. And there's some places have 7%, some places have 4%. But we got a couple papers here that kind of look at this. Paper 5 says that 5 milligrams of 4% cocaine, so that's about what you might use, 5 mils of the lower concentration, 4% cocaine, that's 200 milligrams of cocaine. How does that compare? A typical line of cocaine on the coffee table, snorted through a $100 bill, depending on whose cocaine and what razor blade you're using to make it into a line, is about 60 to 100 milligrams. So 200 milligrams is by no means a small hit. It's too hefty of cocaine if you were nasally insufflating it. And so these are not insignificant amounts to consider. And so this author in Abstract 5 said, while it's generally safe in adults, that's only generally. That some questions ought to precede the usage of cocaine in adults if you were going to use it, and you better check for coronary artery disease and whether or not they're on any endogenous catechols or beta stimulants. You better check for pseudocholinesterase deficiency, a question I always ask. Always. Hey, sir, any pseudocholesterol, it's kind of, I love it when papers say this. It's like, yeah, you're going to roll that one out. And then that you ought to also look for meds, like, for example, if they're a myasthenic and they're on a cholinesterase inhibitor, that would be a really bad idea, too. That one you might figure out. I mean, usually you get to see someone's meds and their past medical history. But that this thing is dangerous. And how dangerous is it? The oft-quoted famous paper, New England Journal, 1989, Abstract 6, when people say, yeah, you can't give cocaine if people with coronary disease, is this paper 6. It's from Parkland, 45 patients on the cath table. Okay, they were either intubated or had an NG tube or what else they had there, and they developed nosebleed during cath. And so they got some nasal cocaine while they were imaging them. What better way to see what the effect was? This paper will never be repeated, obviously. The results are startling. People mention it all the time. Dramatic increases in blood pressure, no surprise. Dramatic increases in heart rate, no surprise. 33% increase in coronary artery resistance across all the coronary bed. And LAD and circ spasm diffusely with ischemic consequences in several patients. So there's not much doubt that cocaine causes major problems with vasospasm in people, and this was just the visual representation of it. Abstract 7 says, and be careful out there, that if you use cocaine on someone to control a nosebleed, and it does work really well, but that the vasoconstrictive issues can persist for some time, much longer than you might consider the half-life of the drug to be, because there are active metabolites. And while the peak level of the drug is 30 minutes, the active metabolites might peak as far as 90 or 120 minutes out. And so that if you were to use cocaine on someone and you were thinking, okay, everything looks good, you might want to watch them for 2 hours. That's kind of unsavory. But that's what it suggests. And active metabolites, it's kind of interesting. If you talk to I've kind of alluded a couple times that we have an interesting drug-abusing population, and we have the jail and things at LA County. And when you talk to them, they're remarkably sophisticated about the drugs that they use. Like no one, as far as, and I know Los Angeles well, but I believe no one in the United States would smoke rock cocaine without being drunk first. They know very clearly your alcohol level should be between 1 and 150 when you take your first hit of your rock cocaine on your crack pipe. And the reason is because if you just smoke the crack straight up, your high will max through smoke route at around 20 minutes and be dissipating by about an hour, which, for a $20 investment is not bad, but you can do better. And you can do better by being drunk first, and then you'll make cocaethylene. If your alcohol level's about 1 to 150 when you smoke, you'll rapidly form cocaethylene, which has all the euphoric and vasoconstrictive, unfortunately, effects of cocaine, but has a half-life of about 4 to 6 hours. So now you'll be lit for a good portion of the evening if you manage to do that. And they always drink the same things which cause strokes. They won't be drinking whiskey. And they won't be drinking vodka because rock cocaine pipes have bad screens. Rock cocaine burns at a high temperature, so it torches your throat. And so when you're smoking your rock cocaine, you need something gulpable, cold, and strong. Let's say malt liquor. And that's why it's used for those purposes. It's, you know, part of that whole marketing punch is to go to that community. Or you drink Irish rose wine or one of those things. But vodka or cocaine are not, you know, particularly if the screen gets sucked out and you hear that and you look in someone's throat and they got like a steak mark on their uvula, which happens every once in a while. We've published some papers on it. You know, that's the consequences of this. They need something cool and gulpable because of the half-lives. 8 is a paper that reminds you that if you're giving something like TAC, which was used in many eras and still is used in some, tetracaine, adrenaline, and cocaine, that cocaine sensitizes your response to catechols, like adrenaline, which is part of the mix. What that means is that if you have cocaine on board, if you see someone with cocaine and you were to give them, you know, a portion of an amp of epi or an albuterol inhaler because they were wheezing, the magnitude and duration of tachycardia and hypertension that are going to happen in response to that catechol are markedly bumped up under the influence of the cocaine. Cocaine sensitizes you to catechols. And so, be very careful with this. This paper of 30 of adults, where they looked at this, 10% of them had problems. Some got this weird, paradoxical, profound bradycardia, and one had a run of VTAC. The bradycardia comes from a cocaine-induced central vagal stimulation and responds to atropine, but you got to be very careful with that. And if you look at the deaths, not reported here, but there are these case reports of kids who died from TAC. Some of them are dental, some of them are emergency medicine cases, where someone inadvertently put, you know, a little, you know, cotton ball soaked in tetracaine, adrenaline, and cocaine on an intraoral lac. Here, kitty. You know, before they were going to sew that up. Some of those kids have died. In one of the case reports, the kid dies, he bleeds in his head, but before he bleeds in his head, he has a blood pressure of 310 over 250 and a heart rate of 250 before the O-ring let loose. All of that is evidence of the sensitization of to catechols from cocaine. So remember, cocaine on board, you really don't want to start beta stimulating them because what you're going to get on the other side is a bit of a cocaine rage in terms of their autonomic nervous system. And so cocaine largely gone. Those papers I think are important because we see not so much for, you know, are you going to be using cocaine, but they're reminders of us about the basic physiology of cocaine, and most of us who work in an emergency room are still seeing rock cocaine and nasally insufflated cocaine, and so I think they're useful from that standpoint. They're not so important from the nosebleed literature because many people aren't using cocaine anymore. The alternative papers are 9 and 10 that say, well, there's other things that you can use. You can use 4% lidocaine. That'll get you the anesthesia, and indeed it will. I don't find 4% lidocaine in most of the ERs I work in. It's hard to find, but you can use 2% lidocaine with epi, just like you would get to sew a laceration up on a hand. Not on the finger, obviously. But that 2% with epi, just neb it. Neb it to your nosebleed, put it in a neb, let them breathe that, and they'll get the vasoconstriction from the epi, the numbness from the lidocaine, and then you can start doing what you want to do about their nosebleed, and it works quite nicely. You can, this paper, Abstract 9, looks at adding 0.5% phenylephrine, and says that 6 sprays of that combination would give you a total of 24 milligrams of lidocaine. Not a big concern compared to the 200 milligrams of cocaine you got from 5 cc's of 4% cocaine. A much, much safer alternative. Abstract 10 looks at topical analgesia, compares 4% cocaine with lidocaine, 2% with oxymetazoline, which is another one of the vasoconstrictors, or tetracaine with oxymetazoline, and tetracaine was the winner. Tetracaine 1% with 0.5% was the winner by quite a bit in terms of visual analog score pain releases. And I don't really think it matters which of these alternatives you choose. There are alternatives, you can use them well with good results is the point. 11 says, all right, so you're getting around to thinking you got to jam something up the nose. The nosebleed is not something you can control with just direct pressure, or you may have tried a silver nitrate cautery stick and the nose is still bleeding, which is quite common in the emergency room. So you're entertaining packing either anteriorly or posteriorly or both. And there's the balloons, there's the rhino rocket, there's the rapid rhino. How upset would you have been if you invented the rhino rocket and the other company called theirs the rapid rhino? That would piss you off, I think. But anyway, there's all these devices. There's the Miracell gel. There's the mixable stuff that's like a Surgicel. And they all work pretty well in varying hands. And most, if I was to query a group of ER docs, people would have their own preferences. I personally prefer the Miracell gel, but that's me. But 11 points out that if you're seeing people and you're packing their nose either anteriorly or posteriorly, and especially if you're going posteriorly, that there are some things to remember when you're packing a nose. First off, if it's a small kid with a nosebleed, you need to remember that some kids are nasal obligate breathers, particularly under 6 months, but sometimes lasting up to a year. We all know this because these kids come in with the flu and boogers and fever, and sometimes they look terrible until you suction, a large game out of their noses, and then they look great. And so we know that. And so packing one nostril in a kid who has an upper respiratory tract infection can be a problem for their breathing ability. It also goes on to point out that in COPDers, and COPDers get a lot of nosebleeds. Why so? Oxygen, so they got the dry, they got the D. And they may smoke, which may make their D worse. And one other thing, they have elevated right-sided pulmonary pressures. Remember, ultimately, COPD leads to cor pulmonale, and those elevated pressures decrease venous drainage from the head and fill all the venous plexuses in their face and beak. So if their nose bleeds, it tends to bleed more because their venous pressures are elevated due to some component of cor pulmonale and pulmonary hypertension. So they're going to bleed a lot more when they do bleed, and so they usually need packed. On the flip side of that is the fact that they are a pulmonary disease patient with limited pulmonary reserve. And so this paper points out that you got to watch it, that there's this nasovagal reflex. And so you got to be careful if you're going to be packing a COPD or someone with pulmonary disease. Do not over-sedate them. They should be managed. The paper says pulse ox and also talks about things like ABGs. I don't know if you need a routine ABG, but if the patient looks crappy, you might consider it. And they say also consider antibiotics because they can have some bacteremia, particularly with posterior packing. Antibiotics are standard. Most people would say you don't need to antibiotics a simple anterior pack, but consider it on patients who are sicker. And so this paper points out that there are patients who have had problems with nasal packing. So all the problems with nasal packings. The most important one is the concept of this nasovagal reflex with hypoxia, desaturation, and respiratory problems that you're going to see in chronic lungers. The next problem is that if you leave it in there too long, or if you pack it in two pieces or use two gauzes up there and the person only pulls one out, then they're going to be left with fabric up their nose. We already had that conversation. If there's cotton or fabric up your nose, you're going to get toxic shock. It's a tampon up the nose, basically, and that's what you're going to end up with. Sinusitis is a complication. So people who have, sinus pain and tenderness and drainage after having their nose packed might, in fact, need sinusitis treatment. And you would probably be more liberal with treating that sinusitis because it's iatrogenic as opposed to, did Jerry already give the sinusitis talk? Sinusitis, not so simple is the truth, but certainly when it's iatrogenic, the threshold for treatment drops a little bit, right? It's different from someone who has another cause of sinusitis. And then the bacteremia issue. And there are patients with this nasovagal reflex that this paper talks about, that because of the hypoxia and problems in this nasovagal reflex, they're hypoxic, they get bradycardic, and this paper talks about some patients eventually having cardiovascular collapse as a consequence of a nose packing, particularly bad COPDers. So I don't think it's common. I'm not telling you to be, terrified about packing a nose, but you got a bad, sick COPD or home oxygen dependent, end stage disease, big florid nosebleed, you're packing them, consider bringing them in, make sure they're monitored, and don't over-sedate them so that you don't end up in the doo-doo space having to intubate them as a consequence of your nasal packing. It would be bad. So I think 11, although it's not an everyday event, is an important cautionary tale. 12 is by Adam Singer. Adam Singer works with Peter Viccellio, who's faculty for us in Long Island at Stony Brook. And Adam Singer is one of the publishing machines. His real specialty is wound care. But the nosebleed is sort of a wound of sorts, and so he weighed in on the topic, and he compared via the study 12 the rapid rhino and the rocket, and the rapid rhino was less painful than the rocket, but both were pretty equally effective. I think the pain of putting one of those things up there depends not so much on the device as it does on your preparation. If you give them an inhaled lidocaine and squirt some viscous up there if you need to, and prep the patient right and get everything set, I don't find them that painful. I think they ease in easily. And I like to use the Miracell, and when they're in there, if they're not puffing up right away, I'll drip a little lidocaine with that. Gives them a little puff and a little added vasoconstriction. If you need to put 2 of them up there, that's fine. Anytime you put more than one thing in the nose, the patient needs to know there's more than one thing in the nose. Make sure they get 2 things out. I put 2 things in, 2 things got to come out. So that's an important part of the aftercare. If you put 2 Miracells or 2 Rhino Rockets or 2 Rapid Rhinos or 2 whatever's up there, 2 things got to come out because the one doesn't control it. So you'll see, particularly in COPDers, you put one up there and they're oozing around it and they're still swallowing a lot of blood and you're thinking it's not enough pressure, and so you'll kind of put a nasal speculum in and edge one either medially or laterally, whichever way it looks like there's more room depending on the shape of their proboscis. In my case, you might need 3. I have a generous nose. But anyway, edge it to the side and then slip the other one in alongside it, and it'll be firmer with its pressure. And so not everyone's nasal concha are similarly shaped in size. And you know this from looking at CT scans. When you look at CT scans that come down into the face, some people have huge sphenoid sinuses and big spaces in there. Some people are very tight. Some people have a lot of edema. The nasal conch architecture is very variable. So the concept that one nasal tampon, pick the brand of your choice, is going to fix all is just false. Sometimes they won't. And the magnitude of the forces that result in the bleeding, as I've already alluded to, are very different across the patient spectrum. If it's just a Kesselbach's plexus erosion due to dryness and digital trauma, the likelihood that you're going to need 2 of them up there is low. If it's a more posterior bleed, but not a true posterior, but it's like inferior to a nasal concha or along there, the likelihood of needing 2 goes up substantially. So there's both anatomic considerations in terms of variability, anatomic considerations in terms of the location of the bleed, etc. Posterior bleeds are much harder to get to, and most people nowadays with posterior bleeds, I don't have papers that specifically deal with this, would say that the balloon devices, right, the 2-chamber, the posterior balloon and the anterior balloon work best, and I would agree with that. The skill, in fact, some people in this room might be good at it, but I think that it's become sort of a lost art, the ability to use a bayonet forceps to layer in a packing into the posterior chamber to get a posterior nosebleed. I don't think anyone's very good at that anymore in emergency medicine, and the balloon devices have largely obviated the need to become good at it. So I think that's kind of a gone skill. Now, those balloons don't always stop posterior nosebleeds, and posterior nosebleeds in elderly patients, which is what they mostly are, usually over the age of 60, it's important to note that almost all of them have real pathology. They got something back there. And the balloon may not stop it, and they should be admitted, they should be antibioticed, they should be consulted on by ENT. You might need an interventional radiologist to stop the bleeding. They can be truly life-threatening events. Nasal foreign bodies. Let's talk about that next. There are all kinds of tricks of the trade that are out there for nasal foreign bodies. Clearly, the best trick that's come up recently is the reverse mouth-to-mouth, right? You ask mom, you put some, neosynephrine up the nose where the foreign body is. You occlude the other nair, and you ask mom to get down there and do a sharp blast of mouth-to-mouth, as hard as she can. And what happens is the kid reflexively closes their glottis, so there's no barotrauma to the lungs, and all the air comes out the nair with the foreign body. And the foreign body quite frequently shoots out, along with copious mucus and phlegm, into mom's hair. Now, the last time I asked a mother to do this, and I remember it quite clearly, I said, listen, I'd like to try, your kid's got a foreign body, we can't reach it, it's out of reach, I can see it on the x-ray, we're going to have to get it out. I'd like to try this thing. If I can't do this, the kid's going to need surgery. Are you willing to help me? She's like, what do you mean? I said, well, you might get boogers and stuff in your hair. She goes, I raised this kid. They've vomited on me. They've shit on me. They've, you think boogers in my hair is a big problem at this junction? Okay, I'm the mother. I said, okay. And then, so we did it, and the thing shot right out into her hair as predicted. And afterwards, she asked how much she should bill for it, which I found humorous. So there's the mom reverse mouth to mouth. And there's other devices out there like the Beamsley Blaster, which is another version of that. I don't know if you can look that up on the web. The Beamsley Blaster is just a device to do this, where you hook a Christmas tree up, put it to a mask, put it in their mouth, boom, and it comes out. And you can use a bag valve mask to try it as well. It's harder to occlude the affected nair. But nasal foreign bodies come out a lot easier in general than ear foreign bodies, as we said earlier. Now, when they swell, and when they've been in there for a couple of days, in other words, the kid with purulent, foul-smelling drainage, those can be tough. But usually you can shrink the membranes down with some neosynephrine, numb them up adequately, make an attempt and go for it. They might need conscious sedation, things like ketamine to do it, but usually you can get them. Do you need x-rays to do these? It depends on what's up their nose. Most foreign bodies in the nose are like foreign bodies in the bronchus of kids. They're radioopaque. One kid I saw recently, and I just have to tell the story because if it happens to you, kids, you know those little refrigerator magnets, the little circular ones? So this kid had put one up one nose, and that didn't feel good enough, so he put one up the other nose, and on the x-ray, they were attached to each other across his nasal septum, right about here. And I could just see one of them on one side with a nasal speculum, and he was about 5. And I was thinking to myself, as I left the bedside to kind of plot my course, even if I get one out, if I hold the kid down and sedate the kid enough to get one, what's the chances of me getting the other one out? I'm going to have to ketamine the kid if I'm going to go after these things with a forceps or something. There's no way that's going to work. And I'm thinking, this is bad. They're far up there. I'm already thinking this might be beyond my needs. And and it's a Saturday night. Am I going to call the ENT doctor? So I'm walking around seeing other patients while I'm mulling this over. I haven't even told the mom my plan yet. She's sitting there anxiously. And just by luck, by good fortune, as I was walking around, I just happened to see, oh yeah, the cardiac magnet. It had been out because we had a pacemaker patient that had been interrogated. You know that big circular magnet that they put over pacemakers and AICDs? And I was thinking, So I brought it over to the kid. I said, look into the magnet, look into the hole. So he looked into the center of the hole, and the 2 magnets that were in his nose were overpowered by the cardiac magnet and shot out of his nose and went whack. I've rarely been so pleased with myself. Rarely been so pleased with myself. It was better than a great save resuscitation others. I was like quietly giggling to myself for about a week after that.
You glad they didn't shoot him further?
Yeah, well, so I've been asked that. How do you know they wouldn't be repelled and be launched into his brain? But I figured they would come out. I figured that would be what would happen. And that's indeed what happened. In terms of foreign bodies, we've got abstract 14. It looks at almost 100 of them. Says that some of these we're going to need, this is fractures now. Let's talk about nasal fractures. So foreign bodies, what are some of the techniques? Bayonet forceps, Beamsley Blaster or mom reverse mouth to mouth, that kind of thing. Use nasal speculums, use vasoconstrictants to get them better. Most of the time they're going to come out under direct visualization. In kids who can't cooperate with you, you're frequently going to need to ketamine or conscious sedation. Although the literature doesn't say this as clearly and the success rate is higher in the nose than it is in the ear, I would again reiterate what I said about the ear, which is for the nose, which is that if you've made your best attempt and you don't get it, raise the white flag of surrender. The ENTs have superior tools and skills and knowledge of the anatomy and will do a better job. So it looks like you'll get about, from the literature, if you were to survey this stuff, you'll get probably more of these out, 75, 80%, maybe 85% in some series you'll get out successfully. The second thing I will remind you is way more than the ear, way more than the ear. In the ear, it's usually one foreign body. I don't know what it is about the nose, but there's multiple. Once a kid starts stuffing stuff up his nose, one thing goes up the nose, one lentil, let's see a fava bean. Okay, the fava bean successfully up there. Okay, let's try one of these. And so you have to be really careful with nose foreign bodies, particularly with kids, that there isn't more than one there. All right, nasal fractures. Do you need an x-ray of a broken nose? The answer is pretty clear in the literature, no. Do patients want an x-ray of their broken nose? Quite frequently, yes. Is this worth breaking down your doctor-patient alliance and the refusal to get a nasal film? Probably not. Go ahead, humor them. And there's one other case that's not a medical need where you might be faced with the need to get a nasal film, is in some states, and some of you may work in them, if an assault produces a broken bone, it changes the gravity of the charges from misdemeanor to felony. So a broken nose, if you document it, changes the assault from a misdemeanor assault to a felony assault, and so there can be forensic relevance. in terms of our ability as ER docs to interpret nasal films, the cartilage lines come up, and a lot of people call things that are broken that aren't. So you kind of got to know a little bit of anatomy to read them appropriately. And so there are false positives and false negatives in terms of the plain film wet read. Abstract 14, it comes from Wales. What does it say? You don't have to go any further. I told you the origin of the paper. It says you don't need them. That's what it says. X-rays don't contribute to management. And by the way, in terms of where things are in the nose, when someone comes in with a big swollen nose, been popped in the nose, you don't know what it's going to look like at the end. Sometimes you can tell the septum's way off midline, and you can sometimes acutely adjust those, and I certainly do it in the county where I know follow-up's a problem on an occasional basis, give them a little, over. But outside of knowing where the midline of the nose is, it's very difficult to say what's going to happen with the rest of the swelling, whether it'll look good or not. So cosmesis judgments are hard in the acute broken nose. Abstract 15 deals with this, says cosmesis is not related to the presence or absence of a fracture, and it is the most important patient-oriented outcome. So basically 40% of the patients with fractures needed ENT manipulation, without fractures rather, still needed ENT manipulation. So the presence or absence of the fracture didn't determine whether they needed ENT manipulation, because the ENT might manipulate the cartilage, not the bone. And so the presence or absence of fracture doesn't tell you whether they need manipulation down the road after it cools off and the swelling goes down. So that's kind of important. And outcomes of were a cosmetic problem in nose fractures. How often is it? Everyone looks terrible when you first see them. Big swollen nose, maybe a little black eye, the thing all looks lopsided. But this paper I think is an important one because cosmesis really was the thing they looked at. And they said that cosmesis is a problem, and this is your patients will ask you, am I going to look okay? You can say, listen, 9 out of 10 patients who start looking like you come out fine with no surgery or manipulation needed. Because in this paper, 11% of them had a cosmetic issue with their outcome, where something had to be done. I think that's a reassuring number to tell your patients. Treatment is based on the clinical, not the radiographs, is what 16 says. 17 is an Irish paper. You know what it says. It says you don't need the x-rays. 18 is a U of T paper. You know what it says. You don't need the x-rays. 19 is a bizarre paper which kind of deals with a second thing. It's a Korean paper that looks at not the isolated broken nose. It looks at people who have broken nose as a consequence of deceleration injuries and things like that. So if you've got a broken nose from hitting the windshield, what are the chances that your beak was the only thing busted? Right? You got a broken nose from a 3-story fall. What are the chances that your nose actually cushioned all the deceleration? Not very high. And so this person, you got to be careful how you read this one. If you read this as saying, oh, someone who might have a broken nose needs a CT of the face, you would totally get the wrong conclusion. What it says, in someone with major trauma to their face, if they got a broken nose, you probably ought to CT their face because they're going to have other fractures. And indeed, they found deviation in this series present 60% of the time, depression 56% of the time, and the reason they recommended CT is because associated injuries were found 27% of the time. But these are people with major deceleration injuries. It's kind of an interesting thing. ATLS would tell you if you have trauma, the ATLS says above the neck, then you need to worry about C-spine films. In other words, does a person with a broken jaw need a C-spine series? No, they don't. Does a person with an isolated broken nose need a C-spine series? No, they don't, because ATLS did it the wrong way. What they said is we checked all the people with broken necks, and a lot of them had broken faces. Ergo, if you have a broken face, worry about a broken neck. That's not the question you want asked. What you want to know is, of the people with broken faces, how many have broken necks? That's the question you want to ask. We know the incidence of broken necks, you heard it from the C-spine talk earlier, is around 2% overall, the big number globally. If you start with people with broken faces, and this study was done in Canada at Foothills Hospital in Calgary, it's in the EMA database but not in this chapter, what they did was they started with all the broken faces and went backwards to broken necks. The incidence of broken necks, if you have a broken face, is 1%. In other words, having a broken face is protective from having a broken neck. Does that make sense? Oh yeah, it does. The face is the crumple zone for your head. You didn't really evolve it for that purpose, but if you picture yourself having a major deceleration injury and your face is heading forward towards the windshield, if you leaned forward a little bit and your forehead, a nice arch, hit the windshield, so none of the forces were lost. You transmitted all the forces back to your neck, you're going to end up with a broken neck. On the other hand, if you sniffed a little bit at the time of the accident and went into the windshield with your face and did this, click, 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 absorbing all the energy that was there, you would have a Lefort 3, but no broken neck. Now, unfortunately, as you might have gathered, since it didn't decrease it to 0, it only decreased the rate of broken necks by half, many injury mechanisms, about half of them, have more than enough energy in them to break all the bones in your face and break your neck. But the face is kind of a crumple zone. So an isolated broken nose, broken jaw, you don't need neck series if they don't have neck complaints. And they're not altered. You know, you go back to the not altered portion of the nexus rule. All right, that's it for today. Let's get out of here, get outside.